To process this massive amount of data quickly, we've broken it down into 5 clear buckets. First, syndromes and staging updates. Second, differentiated thyroid cancers. Third, anaplastic carcinoma and lymphoma. Fourth, medullary thyroid cancer. And finally, a breakdown of the MEN syndromes.
Kicking things off with Section 1, Syndromes and Staging Updates. We need to lock down the systemic view and the absolute latest AJCC updates that examiners just love to test.
Okay, so you really need to pay attention to the new T3B classification. Previously, staging relied heavily on the sheer size of the tumor, right? But now, actually scratch that. Size doesn't matter at all if those strap muscles are involved. Any gross extrathyroidal extension strictly into the strap muscles automatically makes it T3B. We also have a massive shift in the age cutoff for prognosis, moving from 45 way up to 55 years. And crucially, anaplastic carcinoma is no longer just automatically slapped with a T4 category. It's now staged much more similarly to differentiated thyroid cancers.
This next part brilliantly illustrates how thyroid tumors often show up with a whole constellation of other systemic issues. You've got FAP and Gardner syndrome, which are linked to follicular and papillary variants. Then there's Werner syndrome, and careful, that's not to be confused with Wermer, which is an adult progeroid syndrome linked to papillary, follicular, and Hürthle cell carcinomas. Cowton syndrome brings GI polyps, breast, and thyroid cancers into the mix. But the highly testable one you absolutely need to know is Carney complex. Just remember the Batman mnemonic. Breast, adrenal, thyroid tumors, myxomas, specifically those atrial myxomas, and nevi.
Moving right along to Section 2, differentiated thyroid cancers. We're looking at PTC, FTC, and Hürthle cell. These are your most common and curable forms. They arise from epithelial cells and, importantly, they retain the ability to take up iodine.
There is a stark difference in how these two spread, and it's a real game changer clinically. Papillary thyroid carcinoma, or PTC, is the most common overall. It spreads through the lymphatics, specifically hitting those level 6 and 7 nodes. It's tied strongly to radiation exposure, but the good news? It boasts an incredible 20-year survival rate. On the flip side, follicular thyroid carcinoma, or FTC, is the most common cancer in iodine-deficient areas. FTC spreads hematogenously, meaning it travels through the blood. This often results in these highly vascular, pulsatile, osteolytic bone metastases.
So, the crucial point here is visualizing the histological anchors for PTC. You are gonna constantly see references to clear orphan annii nuclei and psammoma bodies. Those are those tiny foci of dystrophic calcification that you'll also spot in ovarian, renal, and meningioma cancers. The most common genetic driver here? The BRAF mutation. You also absolutely need to know the term lateral aberrant thyroid. Honestly, it's a total misnomer. If you find normal-looking thyroid tissue in a lateral neck lymph node, but you can't feel a mass in the thyroid gland itself, that's a level 6 metastasis from a hidden PTC.
Now, let's talk surgical strategy. Because a simple fine needle aspiration and FNAC literally cannot detect the basement membrane or capsular invasion that clinically defines a follicular carcinoma, you must strictly follow this surgical sequence. You start with a hemithyroidectomy. Then, you send that tissue out for a frozen section while the patient is still on the operating table. You only perform a completion total thyroidectomy if the pathologist confirms it's malignant. If it turns out to just be an adenoma, you're done. No further surgery needed.
Let's see how all of this builds into prognostic scoring for differentiated thyroid cancers. We have 3 main scoring systems: AGES, AIMS, and MASIS. Notice how MASIS is the only scoring system that incorporates a postoperative metric, the completeness of your surgical resection. The others are strictly preoperative assessments. Also, keep in mind that post-surgery, maintaining TSH suppression by giving thyroxine actually improves overall survival in stage 2, 3, and 4 differentiated thyroid cancers. Why? Because it prevents TSH from stimulating any rogue cancer cells left behind.
Okay, plunging straight into Section 3, anaplastic carcinoma and lymphoma. We are talking about aggressive malignancies now. These are the rarest, most aggressive forms of thyroid cancer, where rapid intervention is absolutely paramount.
Both of these are going to present as rapidly enlarging neck masses, but their clinical paths couldn't be more different. Anaplastic carcinoma is notoriously aggressive. We're talking the worst prognosis. It presents as a woody, hard mass that often compresses the trachea or the recurrent laryngeal nerve. Treatment is largely palliative, though we do now have targeted therapies like dabrafenib and trametinib. Thyroid lymphoma, on the other hand, is usually a diffused large B-cell lymphoma arising in patients who have had long-standing Hashimoto's thyroiditis. It presents with classic B symptoms. Think fever and night sweats, and it responds beautifully to the R-CHOP chemotherapy regimen. You usually don't need surgery here.
This brings us to a really major clinical rule. We typically avoid sticking large TrueCut or core needles into a highly vascular, bloody thyroid gland. Usually, FNAC is king, but these three conditions are your strict, highly tested exceptions. You must do a core biopsy for inconclusive anaplastic cases, for characterizing lymphomas because FNAC simply doesn't give you enough tissue architecture to work with, and finally for diagnosing Riedel's fibrosing thyroiditis.
Let's pivot over to Section 4, medullary thyroid cancer. We're focusing on C cells and calcitonin, and we'll see how this builds a bridge right into complex neuroendocrine pathology.
Medullary cancer is entirely driven by parafollicular C cells, and remember, those originate from the neural crest, not the thyroid epithelium. These cells secrete calcitonin and CEA. On histology, you're looking for an amyloid-rich stroma that stains this beautiful cherry blossom pink. Clinically speaking, monitoring the calcitonin doubling time is literally your single best tool for spotting recurrence. A rising CEA is also a clear sign of dedifferentiation, pointing to a much more aggressive tumor. And get this, because of systemic hormone secretion, these patients might shockingly present with diarrhea driven by serotonin, or even Cushing's syndrome driven by ACTH.
MTC is uniquely aggressive, so surgeons employ what's called the one-step-ahead rule. With papillary cancer, a localized tumor just gets a total thyroidectomy. But with medullary, if it's localized, we stay one step ahead by doing a total thyroidectomy plus a prophylactic central neck dissection right off the bat. If those central level 6 nodes are already involved, we escalate again, adding a modified radical neck dissection. You just have to be incredibly aggressive right from the start.
Listen closely to this one because examiners love to trick people on it. C cells do not eat iodine for breakfast. Because medullary thyroid cancer does not originate from thyroid epithelial cells, it physically cannot take up iodine. Therefore, there is zero, and I mean zero, role for radioactive iodine ablation here. Do not let anyone trick you into giving these patients RAI.
We are finishing up our rapid-fire review with Section 5, Men's Syndromes Breakdown. Let's look at the genetic links.
Let's break these down. Lock in the 3 Ps for MN1, which is also known as Wermer syndrome, driven by the menin gene on chromosome 11. You get pituitary tumors, most commonly prolactinomas, parathyroid adenomas, and pancreatic endocrine tumors, most commonly gastronomas. Now, compare that to the newer MN4 syndrome, which is driven by the CDKN1B gene. MN4 has the pituitary and parathyroid issues, plus renal and adrenal tumors. But the key differentiator? MN4 entirely lacks those pancreatic endocrine tumors. Now, notice how the RET proto-oncogene basically dictates the exact phenotype in MEN2. Both of these variations share the RET mutation and present with medullary thyroid cancer. But MEN2A, or simple syndrome, is driven by exon 63 and features pheochromocytomas and parathyroid issues. MEN2B, on the other hand, driven by exon 918, is just viciously aggressive. It lacks the parathyroid issues, but it features distinct marfanoid physical traits, mucosal neuromas on the tongue and lips, and megacolon.
Because medullary cancer in these syndromes is just so deadly, we routinely test first-degree relatives for RET mutations and actually perform prophylactic thyroidectomies based on the exact exon mutated. These specific exons dictate our surgical timeline. For low-risk mutations, surgery happens around age 20. For medium risk, like exon 634, we operate around age 5 to 6. But if a child has the high-risk exon 918 mutation associated with MN2B, we remove their thyroid by their very first birthday.